Well, the first thing is you really have to look at where the costs are, and they're split between the pharmacy and the medical benefit. And if you don't look at both, then you're not going to get control. More importantly, though, you really have to look at outcomes and not just cost. So there's a lot of information now that's beginning to come out where you're seeing that an investment in the drug itself is resulting in decrease in medical costs. So the idea that you're just going to focus on drug costs is short-sighted if you don't really look at the impact that they're having overall. And if you don't combine a methodology to look at medical and pharmacy together, then you're missing half of the cost that's out there. So whatever program it is, whether it's a plan or an employer or a PBM or any type of provider, they have to look at that whole outcome piece and not just one element of it to get control.
What types of roles do you see PBMs evolving into?
Well, PBMs are in a perfect position to really control that spread and specialty over the medical and the pharmacy benefit. And it depends on whether you are a captured PBM within a health plan or whether you're a standalone PBM on your access to those informations that's going to allow you to do that. And as medical technology and claims information becomes more broadly available, all those entities will be able to really use that information to really position themselves to control it on behalf of an employer or a plan, regardless of whether it's their own plan or an external plan. And so that's the most important thing. And PBMs are really sitting in a nice place because they have access to pharmacy claims. If they can get access to medical claims and all the other expenses to go with it, then they're the ones that are going to be able to provide this to the people that are paying for it ultimately. And that's really where PBMs are well suited to do this today.
What are some of the unforeseen complications of health reform that people just aren't paying attention to yet?
The health reform exchanges are bringing forward an opportunity to control costs. The physicians and anyone, the hospitals and anyone that plays in the health exchange game is going to have skin in the game. So they're going to have to focus on the things where the most expensive elements are. That's primarily hospital costs and physician costs. Drug costs are only about 10% of the whole picture of total costs in the United States. So they're really going to have to focus on that. The opportunity or the threat could be who's going to manage those drug costs and what's it going to do the overall cost proposition that those that own the exchange or the ACOs are going to put into place. So the unforeseen complication there is how are they going to manage the drugs and what element they're going to use to do that, and is that going to be something that's well controlled or completely out of control? And that's the